Much, Mr. Chairman, and I want to thank all of the witnesses for being here today. This is a very serious subject, but I've got to refute some things that I've heard today, or at least one in particular. I think we're comparing apples and oranges when we try to bring in fentanyl and opioid abuse into the debate over whether you want Obamacare, Medicaid expansion, or the American Health Care Act. And in fact, what I've heard repeatedly is that somehow Medicaid expansion has helped to solve this problem, but the map of deaths of opioid use that we saw earlier that Dr. Burgess put up, and I've got a paper copy here, shows us that's not the case. And I think it's apples and oranges. I don't think Obamacare caused opioid abuse. I don't think that Obamacare is going to solve it on its own. We're trying to find those answers here today. I don't think the American Health Care Act is going to be able to solve it in and of itself on its own. But when you look at the states where the deaths are, you know, if you're just going to play games with numbers, the expansion states seem to have more deaths than the non-expansion states. Now, do I think that's fair? No, I don't. I think that's horse hockey. But I think that what my colleagues on the other side of the aisle have said about us causing problems by voting for the American Health Care Act is irrelevant to our discussion today. So with that being said, Dr. Compton, you mentioned the Appalachian Regional Commission and that you're all working on a project with them. What exactly are you doing? That's my turf, in part. I represent Southwest Virginia, the Appalachian regions of Southwest Virginia, which of course border hotspot areas for opioid abuse in Kentucky and West Virginia, and it spills over into my district as well.
Well, I certainly remember a terrific meeting in Wise, Virginia. It's a lovely town that convened a group from all across the Appalachian region to look at this issue several months ago. Our initiative with the Appalachian Regional Commission is a grant program to look at demonstration projects to improve the public health infrastructure and determine how good a job that'll do to address the opioid crisis in rural parts of the country. And the Appalachian Regional Commission will be co-funding this along with SAMHSA, the CDC, and of course NIDA taking the lead on it.
Well, we appreciate it because it is a significant problem, and one of the issues there that we have to look at is that whether or not the folks started off because of it's a high area for disabilities as well. People have done for years a lot of hard manual work, and that they get a prescription and then they get hooked. Dr. Howry, you indicated in Ohio at least that 62% of the people who died from heroin or fentanyl had in the last 7 years had a prescription drug for an opioid. Can you talk more about that?
Sure, we've been seeing this in many states. Like in Rhode Island, a third of the people who had overdosed on fentanyl had an opioid prescription within 3 months, and a third of those had a high-dose opioid prescription, showing that people that are on prescription opioids get addicted to opioids and can then go on to overdose from heroin or fentanyl.
And sometimes their prescription runs out, but they're hooked, and is there some way we can connect the doctors recognizing that maybe their patient has gotten hooked to get them the help? Because if the prescription just ends and nobody's alerting anybody, aren't those a lot of the folks who are going out and buying it then illegally on the street somewhere?
Well, and I think that's why we've got our CDC prescribing guideline, where we did talk in there about if you have a patient that you suspect opioid use disorder on, about the importance of linking them to treatment. And I think one of the things that I've been really proud about the work CDC is doing is, although we're funding the states to do what's most important for the states, each month we do technical assistance calls to help them with their data and provide scientific expertise on where to really focus resources and what are the best evidence-based treatments, and then have a convening of all the states to share these best practices. That way, as we're seeing different things emerge in different states, we can share those. I think, data does drive action, and I heard us talk about, should this be a national or a state approach? New Hampshire was number 20 one year for overdoses. The following year it was number 5. So I think we need to give states the flexibility to deal with what's going on in their state, but we need to have that overall approach.
Yes, ma'am. Thank you very much. Mr. Million, if I said that right, and I apologize if I messed it up, but I'd be remiss. While I think that marijuana is a dangerous drug, I think your testimony here today indicated that fentanyl was your #1 concern, and it's not your jurisdiction, so it's a rhetorical question I asked you just to take back. Why don't we let there be more research on marijuana and its ability to help patients, whether it be epilepsy or in this case pain? Because while I think it's a dangerous drug, I don't think it's as dangerous as fentanyl and other opioids. With that, Mr. Chairman, I yield back.
If I could say in response to that, we support any approved research along those lines. So we will continue to work with the researchers on those things, and we support that.
Well, if I might, Mr. Chairman, it's just the problem is, as a Schedule I drug, it makes it tougher than it would be if it were Schedule II, like fentanyl and other opioids.
Gentleman yields back, recognizes Mr. Pallone for 5 minutes.
Thank you, Mr. Chairman. The Affordable Care Act, through the expansion